Good evening, everyone. Welcome to the PACS Journal Forum, Episode 2. We got great reviews and lot of learnings from the last episode, which was on fibroneer trial by Professor Toby Mayer. And today we have another yet a very exciting trial to discuss, which is the Mandara study. We also have a dipstick test in pleural fluid and its applications in India by Professor Asmita Mehta and her colleagues. So we have got two very good research publications to be discussed and see that how it blends with our practice in India. PACS Journal Forum is primarily from the editor of JPACS, and JPACS editor is Arjun Khanna. He is assisted along with that with Dr. Manu Madan, and I think they are the two people who will be carrying this program further onwards. So I'll hand over to Arjun to carry on with the proceedings today.
Thank you, sir. Hello, good evening, everyone. I hope everyone is doing well, and I hope you enjoyed the last meeting. The response that we got was excellent. And today we have another interesting trials to discuss. And as I said before, the purpose of this meeting is to incite the interest into research. JPACS is just a way into doing that. We have published now 3 editions have come out. The 4th one should be out soon. And with the kind of response that we've got has been overwhelming. And I would really like to thank all the people who have applied and who have kind of, submitted their articles, have put their trust in us. And we assure you that the kind of hard work and, everything is on the right track. And hopefully, after the next edition at PACS this year, we should be giving you one great news about our journal. So 2 articles today. The first is an internationally acclaimed article, the Mandara study, gives you a lot of research ideas how drugs can be repurposed into indications which are not their primary indication. And if you go through the trial, you'll find out there are so many questions that a researcher, a young person who wants to start research would have these questions. And we are so happy that, we have the original author of this article, Professor Michael Wexler from the National Jewish here with us today. The other article is from Amrita Institute of Medical Sciences, Kochi, another indigenous Indian research, which again will incite a lot of questions. I'm joined by a stellar panel today. With me, I have Dr. Mir Ilyas, who's a senior consultant pulmonologist at Srinagar. I have Dr. Shweta Bansal. Shweta is a senior consultant transplant pulmonologist from Delhi NCR. We have Dr. Mansi Gupta, who's an associate professor of pulmonary medicine from the prestigious SGPGI Lucknow. And we have Dr. Milind Balvi, who's a senior consultant DM pulmonary medicine from PGI Chandigarh. And 4 of them, they have a rich research background and would be helping me and Manu in asking research-based questions from both the authors. I thank all of you for being with us here today. Can I please ask Dr. Professor Michael Wexler to take stage and enlighten us about the Mandara trial?
Yes, thank you so much for having me today. It's a pleasure to be here. I'm sorry I'm not there in person, but hopefully at some point I can make my way over there and to speak with you all and meet you all in person. It's a real pleasure to talk about the Mandara trial, which is a study of benralizumab versus mepolizumab in EGPA. And EGPA used to be thought of as a relatively rare disease, but we're seeing it being a much more common entity. And about 9 years ago, we published the MIRROR trial, which I'll briefly talk about, which showed that mepolizumab is an effective therapy in EGPA. But with the emergence of other anti-IL-5 therapies, including benralizumab, we thought it'd be important to do a head-to-head comparison, comparing the efficacy of benralizumab to mepolizumab. And actually, it's one of the only trials of a head-to-head comparison of biologics. There are very few in asthma. There's one that's emerging, the Everest trial. But until now, there have really been only one other trial comparing biologics head-to-head in any of these entities. It was a study I did with itepekimab, an anti-IL-33 agent, and dupilumab. So these are some of my disclosures. Received consulting honorarium from a variety of companies. So, just to get us started, EGPA, or eosinophilic granulomatosis with polyangiitis, used to be known as Churg-Strauss syndrome or allergic angiitis and granulomatosis. It was first described in the 1950s by Jacob Churg and Lottie Strauss when they were doing autopsy series on patients with asthma. And they found that in addition to asthma, these patients had peripheral blood eosinophilia, pulmonary infiltrates, paranasal sinus abnormality, and eosinophilic vasculitis, or what they called vascular embarrassment of various organs and tissues. But the key finding was the markedly elevated eosinophil count, and in many patients, there was evidence of anti-neutrophil cytoplasmic antibodies. So this eosinophilic vasculitis has become an important disease because it can really have an impact on patients' quality of life. It requires systemic corticosteroids. And historically, the treatment options prior to the advent of anti-IL-5 was corticosteroids and cytotoxic agents, including cyclophosphamide, azathioprine. And people have tried other agents, including mycophenolate, methotrexate, and other therapies as well. And those therapies have had variable efficacy and a moderate amount of toxicity. So it's important to recognize all of these different deficiencies of these therapies. These therapies weren't very effective and they were somewhat toxic. So when the anti-IL-5s came out, the concept was that, well, first of all, with just historical treatment with corticosteroids and immunosuppressants, the disease often recurs as patients withdrew their corticosteroids, and very few patients were able to come off of oral corticosteroids, and also not all patients responded to steroids initially, plus there are all the side effects that I mentioned. So when the anti-IL-5s emerged, people started asking, well, what about targeting eosinophils? Because this is eosinophilic granulomatosis with polyangiitis. And that led to the MIRA trial, which we published in the New England Journal of Medicine back in 2017, where we evaluated the efficacy of anti-IL-5 therapy with mepolizumab versus placebo for patients with eosinophilic granulomatosis with polyangiitis. And we demonstrated that there was a significant increase in time to first relapse with mepolizumab compared to placebo, as can be shown here. And we were able to cut the relapse rate in half, going from 2.27 relapses per year down to 1.14. So 50% reduction in exacerbations with anti-IL-5 therapy with mepolizumab. We were also able to get a fair number of patients into remission. Remission being defined as being on 4 milligrams or less of prednisone and having a Birmingham vasculitis score of 0. We were able to get over 30% of patients into remission versus only about 2 or 3% of patients on placebo. So significant benefit, both clinically and statistically, in terms of time to first exacerbation, corticosteroid dosing, and the proportion of patients getting to remission. And importantly, we were also able to facilitate corticosteroid withdrawal, reducing corticosteroids in the mepolizumab group from 11 milligrams down to 5 milligrams over the course of the year. And the placebo group, they stayed around 11 throughout the entire year. So about a 50% reduction in oral steroid dosing. Over 57% of patients were able to get this 50% reduction compared with only 21% in the placebo arm. This led people to ask about other therapies, including benralizumab, which is an anti-IL-5 receptor antagonist that has been approved for asthma. And we did a small pilot study that we published in 2021 in the Journal of Allergy and Clinical Immunology, in which we gave benralizumab to patients with EGPA in an open label fashion. We gave it to 10 patients, and the median corticosteroid dose went from 15 milligrams down to 2 milligrams, and 5 of the 10 patients were able to come off of glucocorticoids completely. And we were able to reduce the mean exacerbation rate from 4.6 events per year down to 1.5 events per year. So this was a pilot study that suggested that we could, in fact, achieve good efficacy with benralizumab. This was followed up by open label experience in the UK by David Jackson, who demonstrated that a large proportion of patients treated with benralizumab, over 70% of patients by 48 weeks, were able to come off of glucocorticoids, whether they were ANCA positive or ANCA negative. So this led to the current Mandara trial that we're here to talk about, the benralizumab versus mepolizumab for eosinophilic granulomatosis with polyangiitis that we published in the New England Journal of Medicine in 2024. This head-to-head trial was a non-inferiority study comparing 30 milligrams of benralizumab a month to 300 milligrams of mepolizumab a month. And it's important to note that the benralizumab dosing for asthma is 30 milligrams a month for 3 months and then every other month. And the mepolizumab dose for asthma is 100 milligrams per month. So we're using higher doses in EGPA because it's more of an eosinophilic disease. This non-inferiority study was the head-to-head trial over a 48-week period where we compared benralizumab to mepolizumab, and patients tapered their oral glucocorticoids throughout the trial. We did a primary analysis at week 52, and then there was an open label extension study as well. And we evaluated the proportion of patients with relapsing or refractory EGPA who were able to achieve remission at both weeks 36 and 48. We took people who were above age 18, who had a diagnosis of EGPA with presence of asthma, eosinophilia, and at least 2 other predefined criteria, and who were on a stable dose of glucocorticoids of at least 7.5 milligrams for the 4 weeks prior to the trial. The discontinuation rate was low and was balanced. We randomized 140 patients, 70 in each arm. As you can see, there was an over 80% completion rate in the open label extension study. But even after the 52-week double-blind treatment period, over 95% of patients were able to complete the trial. So very few patients, only 3 patients in the mepolizumab arm were discontinued. 2 withdrew by the subject and 1 due to an adverse event. But as you can see, many patients wanted to continue these therapies and went on the open label extension as well. So 69 of the 70 in the benralizumab completed, and 67 of the mepolizumab patients completed. The baseline demographics were consistent with what we see in patients with EGPA. The patients were primarily in their 50s, predominantly female. Most of these patients were from North America. There were many patients from Japan and the rest of the world. These were primarily Caucasian patients, and their BMIs were between 25 and 27. This is similar to what we saw in the MIRA trial. You can see very similar numbers across the board in terms of demographics in the Mandara trial versus the prior mepolizumab placebo trial. Other baseline characteristics included absolute eosinophil counts that ranged around 300 to 400. Again, these people were on glucocorticoids. The median glucocorticoid dose was 10 milligrams of prednisone a day. And only about 25 to 31% of these patients had a history of ANCA positivity. Only 10% were ANCA positive at baseline. Patients were allowed to be on immunosuppressive therapy other than cyclophosphamide, and close to 60% of patients throughout the trial were on some type of immunosuppressant at some point, and at baseline, 34 to 37%. They all had some evidence of active vasculitis. They had evidence of active asthma for the most part, as well as active sinus disease. 64% to 68% had relapsing disease, 60% had refractory disease, and the mean time since diagnosis was around 5 years. Number of relapses in the prior 2 years is seen at the bottom. Again, this is very similar and consistent with what we saw in the MIRA trial, very similar kinds of numbers throughout. In terms of EGPA disease history, what characteristics did these patients have? Well, everyone had to have asthma and eosinophilia. 28 to 47% had biopsy evidence of eosinophilic inflammation. 50 to 60% had neuropathy. 60 to 70% had pulmonary infiltrates. Over 90% had sinonasal abnormalities. Cardiomyopathy was in 18 to 24%, and then smaller percentages of glomerulonephritis, alveolar hemorrhage, palpable purpura, and historical ANCA positivity, 23 to 29%. Again, these numbers are very similar to what was seen in the MIRA trial. So what was the primary outcome? The primary outcome was the proportion of patients who were able to achieve remission, which was defined as a Birmingham vasculitis score of 0 and be on 4 milligrams of prednisone or less at weeks 36 and 48. And as you can see, the remission rates were not significantly different between benralizumab and mepolizumab. Benralizumab was thus deemed to be non-inferior to mepolizumab. In fact, 59% of patients treated with benralizumab versus 56% of patients treated with mepolizumab were able to achieve remission. Now, this is great because when we looked at the prior data from the MIRA trial, you can see that 58, 57% of patients were able to achieve remission. When we look back at the mepolizumab arm in the MIRA trial, only 32% of patients were able to achieve remission. So that's significantly better in this trial. And I think it's because there was greater comfort in patients and physicians in terms of tapering their glucocorticoids. This primary endpoint was generally consistent across predefined baseline groups. As you can see, the overall data set throughout, you can see that it is benralizumab was just as effective as mepolizumab and was independent of eosinophil count, independent of BMI, steroid use, gender, age group, geographic region, time since EGPA diagnosis, VDI score, race, and ANCA positivity status. What is interesting is that there was a slight difference in terms of responsiveness in those who were on immunosuppressives. Again, the numbers were small. The number of people who were on immunosuppressives in the study was small, so it's hard to read too much into those data. Achievement of remission and accrued duration of remission were similar between treatment groups, and you can see over the course of time, took around 36 weeks to start achieving significant proportion remission, and those patients generally stayed in remission throughout. And the total accrued duration of remission, as you can see in the left-hand panel, was similar across groups. Time to relapse was similar between treatment groups. In the Mandara trial, you could see benralizumab versus mepolizumab, and those numbers are comparable, actually slightly better than what we saw in the MIRA trial, which looked at placebo. On the far right-hand side at the top is the placebo arm, and below that is the mepolizumab arm. You can see in this trial, on the left-hand side, benralizumab and mepolizumab did quite well, with 21 of 70 patients in each arm able to achieve remission and time to first relapse. The annualized rate of relapses was also similar, around 0.5 relapses in the benralizumab and mepolizumab arms. And in terms of major relapses, 0.06, and that was only seen in the mepolizumab arm. And this compares to the MIRA trial, where it was 1.14 with mepolizumab. So again, we did significantly better in the Mandara trial. There was a nominally significant greater proportion of patients who were able to achieve complete reduction of oral steroids with benralizumab compared to mepolizumab. When we look at on the right-hand side, 86% of benralizumab patients were able to cut their steroid dose in half versus 74% of mepolizumab patients. And then in terms of 100% reduction, coming off of glucocorticoids, 41% of benralizumab versus 26% of mepolizumab patients. So I think this is an important point to highlight. With benralizumab, you're more likely to come off of glucocorticoids. And when we look at the proportion of patients who are able to get down to 4 milligrams or less, it was around 70% of patients in both arms. The average daily oral corticosteroid dose was comparable between the two groups. They started off at around 10 to 11 milligrams a day. They got down to around 4 milligrams a day with both treatment arms. And again, this is comparable to, maybe slightly better than what we saw in the MIRA trial. BVAS also improved in the Mandara trial, similar to what was seen in the MIRA trial. And the vasculitis damage index change from baseline also improved in both benralizumab and mepolizumab arms. similar to what was seen in the MIRA trial. One of the other important components is the reduction in eosinophil counts, and there was a nominally significant difference in change in eosinophil counts from baseline with benralizumab versus mepolizumab. The benralizumab arm, not unexpectedly, ended up with a lower level of eosinophils compared to mepolizumab, and this was significantly different at some time points. But I think this reflects the mechanism of action of benralizumab, which binds to the IL-5 receptor and not only blocks IL-5 from binding, but also can have an impact in terms of causing antibody-dependent cell-mediated cytotoxic events that can obliterate eosinophils. Both benralizumab and mepolizumab were well tolerated in this study, and there was no significant difference in terms of adverse effects. You can see the most common adverse effects were COVID-19. This is when the study was being done. Some of the limitations of these data are that we don't have data in acute disease. We don't have any long-term data. We do have with mepolizumab now, we've got 7-year data suggesting it's safe and well tolerated. And there still is a little bit of uncertainty in ANCA and non-eosinophilic vasculitic components of EGPA, and also the role of these therapies in patients who have a history of immunosuppression. Also, the role of reslizumab and other anti-IL-5, we don't really have much data in that regard. So to summarize, EGPA, or eosinophilic granulomatosis with polyangiitis, is a complex syndrome. It's characterized by asthma, eosinophilia, sinus disease, pulmonary infiltrates, neuropathy, vasculitis. The eosinophil is clearly central to EGPA pathophysiology, and EGPA needs to be distinguished from other causes of eosinophilia and pulmonary eosinophilic syndromes. You should do an extensive workup and consider referral to a specialist with EGPA expertise. But with regard to the Mandara study, it demonstrated non-inferiority of benralizumab versus mepolizumab over 52 weeks in patients with relapsing or refractory EGPA. More benralizumab-treated patients were fully tapered off of glucocorticoids. Blood eosinophil depletion was greater with benralizumab than mepolizumab, and it was well tolerated with safety profiles similar to what was previously seen, with no significant differences between these therapies. This study provides evidence for the efficacy and utility of benralizumab in this population, confirming that eosinophil targeting treatments such as mepolizumab and benralizumab are beneficial for patients with EGPA. And now I make the font size of the anti-IL-5 much bigger. It really ought to be the first-line choice of therapy in patients with EGPA, in patients who receive glucocorticoids. So thank you so much. I'd be happy to take any questions that you have. I think I stuck on time as well. So
yes.
Thank you so much.
Thank you, Professor. That was great indeed. And we've already got a lot of questions. The audience are also asking questions. Before my panelists come online, I'll set the ball rolling. So mechanistically, benralizumab is a biologic which kind of depletes the eosinophils to an absolute zero, and it does that rather fast. Why is it that a non-inferiority trial was done? And is it really non-inferior? By its mechanism of action, it should probably be better than mepolizumab. And also, an extension of the same question. We've seen data on dupilumab and data on mepolizumab being positive in patients with COPD. Same, the same analogy there. If benralizumab is so effective and it can knock down the eosinophils to an absolute zero, why do we talk about non-inferiority trials here? Why does it fare, not better than others?
Yeah, I think in a study like this, where you have a therapy that's well accepted, like mepolizumab, you just want to demonstrate that it's not inferior. In order to do a superiority trial, you need a much larger sample size. And for a rare disease like EGPA, it's a lot more challenging to do that kind of trial. So it comes down to power and sample size and the fact that this is a rare disease. And we just wanted to show that it's non-inferior in that regard. Furthermore, patients are all on glucocorticoids already. So you're going to have an ablated signal to some extent, and you want to make sure that you achieve some signal when you're trying to get a drug approved by the FDA.
Sure. Thank you, sir. Can I please request Dr. Mansi, Dr. Ilyas, and Dr. Shweta to unmute themselves and start? Ilyas, we'll start with you, please. Ilyas, you're not clear. You're not audible.
Am I audible now?
Yeah.
I was saying that it's a wonderful study, and we have read it, and we have certain issues with the diagnostic concept going to the therapy. We would be very hesitant in diagnosing usually unless and until we have substantial, evidence of vasculitis histopathologically, because otherwise, if you do that diagnostic criteria, you have a huge overlap with other syndromes, including APP. First, we want to make sure whether those were excluded or not. Another thing is that if you talk about the study group, there's a difference between the proportion of patients who had demonstrated vasculitis on biopsy. I think it was more in less in benralizumab group than in pembrolizumab group. I think that might have been the reason why steroid taper was easier in the benralizumab group.
Yeah, great question. So first of all, again, the definition of eGPA that was used in terms of diagnostic criteria was asthma plus eosinophilia, and then any two of the other criteria. This is similar to what we utilized in the MERIT trial. Those other criteria included pulmonary infiltrates, sinus disease, vasculitis in one or more end organ, positive ANCA, and neuropathy, amongst other things. You could get into the study without having a biopsy. eGPA is a clinical diagnosis. You don't require a biopsy necessarily in order to establish a diagnosis of eGPA. If you're a good clinician, it can be difficult at times, and perhaps a major confounding diagnosis might be chronic eosinophilic pneumonia, which is very similar because many patients with chronic eosinophilic pneumonia have asthma, eosinophilia, pulmonary infiltrates, and sinus disease. So theoretically, those patients could get into the study as well. You could not get into the study. Patients were excluded for ABPA. Those patients were not allowed into the study. Yes, there was a slight difference in terms of the proportion of patients who had a biopsy at baseline. I don't think that was significant in terms of establishing, the disease status for these patients. The differences were small. Let's see if I can find it.
Plus 30% in benralizumab. Sorry,
Pardon me?
30%. Please recheck that slide.
I can't catch what you're saying.
I said the difference was enormous. I mean, it may not be statistically significant, but there were more patients with vasculitis in the pembrolizumab group. Please confirm it. I would request you to confirm it because you have the slides.
Yeah, let me go back to that. Hold on. So the biopsy evidence, you're right, 29% in the benralizumab versus 47%. I don't think that is again, because the diagnosis of eGPA is a clinical one rather than a biopsy one. I don't think that having had a biopsy is a critical piece of making a diagnosis in this patient population. As you can see, they're very similar across all the other manifestations. So that small difference in terms of the proportion in this small study, I don't think really reflects the fact that there are significant differences clinically or otherwise. And that's borne out by the fact that the data for the outcomes were almost identical with respect to every single outcome. So I don't view too much of a significant difference there. And when you look at ANCA positivity, which is another biomarker of vasculitis, 23 versus 28.6%. Again, not a big difference in this patient population.
Manu.
Hi, Professor Wessler. Congratulations on the great work and thank you for presenting here today. So, I had one question regarding eosinophils again. Although criteria says all patients had to have eosinophilia, but the demography says that not all patients are having eosinophilia more than 150. In the paper, you have mentioned that the range for the Brindali started from 30 eosinophils, while for Mepoli it started from zero. Uh, saying that there were a significant amount of patients who were not having eosinophilia at the time of screening. So, what is the rationale of including such patients?
Yeah, everybody was on at least 7.5 milligrams of prednisone. They all had a history of eosinophilia at some point that led to their diagnosis of EGPA. So when people are on corticosteroids like prednisone or other immunosuppressants, their eosinophil counts are going to be down. So that's why they didn't have such high eosinophils. It's a well-known phenomenon in patients with EGPA.
So when we have decreased eosinophils owing to the therapy the patient was on, maybe corticosteroids patient was on, it has led to decrease in eosinophils, and half the population in the study also had BVAS score of approximately of zero. Only approximately half the patients had more than zero BVAS at presentation. So if the
Yeah.
patient was already having BVAS zero, no eosinophilia, was it justified in including such patients, or we wanted to have more severe patients for better outcomes?
No. The whole point is that again, these people, not all these people had either relapsing or refractory disease. They weren't able to taper their glucocorticoids down below 7.5 milligrams a day. We all know the side effects of glucocorticoids. Either they had relapses or they were refractory. They continued to have symptoms despite steroids, or they weren't able to taper below 7.5 milligrams a day. So even if they don't have active vasculitis, again, the Birmingham Vasculitis Activity Score isn't a great one because what happens with that is, and you can have a BVAS score of zero, even if you've had prior damage. The important thing is do they have damage from the vasculitis? The way that questionnaire is administered is once someone has active vasculitis for 3 months or more, it goes off the BVAS and goes on to the vasculitis damage index score. So it's a nuance of that tool. We've actually developed another EGPA clinical activity score, which doesn't put patients, remove things from the questionnaire, and that's in development and hopefully will be published soon.
Very well. So when we include patients of vasculitis, rituximab is a well-known therapy and accepted therapy for vasculitis. But we had an exclusion criteria for rituximab. So are we positioning rituximab versus IL-5 therapy? Because either we're giving rituximab or we're giving IL-5 therapy. So we want to say it is superior to rituximab.
We didn't study that. Part of the issue is that rituximab is a viable therapy for patients with vasculitis. The data, and you'll see very soon because there's another publication coming out comparing rituximab to azathioprine. It's not the most effective therapy in EGPA. Very few patients are able to get into remission. There have been several studies that have been published in that regard, and patients continue to require glucocorticoids. Plus, there are the immunosuppressive effects of rituximab as well. I reserve use of rituximab in EGPA patients for those who have active vasculitis and who have a positive ANCA with a significant disease component. You'll see that the guidelines are going to be changing in the coming years, and I think we'll be seeing in EGPA less use of rituximab and more use of anti-IL-5.
So we
The
want
data with anti-IL-5 therapies are so much better. Again, we haven't done a head-to-head trial, and we excluded those patients on rituximab. But you'll see there are other studies that are going to be emerging reviewing the efficacy of rituximab. Different patient populations, of course, but it's important to evaluate that in the context of the overall efficacy in this disease.
So would you suggest using a rituximab therapy in ANCA positive vasculitis, ANCA positive EGPA, and using IL-5 therapy in ANCA-negative vasculitis and EGPA?
Well, we showed that regardless of ANCA status, the anti-IL-5 therapies were effective. We've shown that with the MIRA trial with mepolizumab and with the Mandara trial. I think you have to use your clinical judgment and evaluate what is the active process. If there are a significant amount of eosinophils, I definitely would go with an anti-IL-5. There's very little harm in giving both rituximab and mepolizumab or benralizumab. However, rituximab has significant immunosuppressive effects, and you risk infection, you risk lack of response to vaccines, amongst other things, and B cell responses to infections. So I use rituximab with caution, really only people who have clear, demonstrated ANCA positivity who aren't responding to anti-IL-5 therapy.
Thank you. Dr. Shweta, would you have some insight?
So, first of all, congratulations, sir, for a very much clinically relevant study. So
I can't hear you, Dr. Shweta.
You're not audible.
now,
Better.
Better.
so congratulations, sir, for a very much clinically relevant study. So my question is, like, based on the study, is there any patient profile where would you prefer one molecule over the other?
You're saying benralizumab versus mepolizumab?
Yes, sir. Yes, sir. Yes. Sir.
No, I think both of them are very good therapies. The benefits of benralizumab versus mepolizumab come down to one, the number of injections. With mepolizumab, you need 3 injections per month. With benralizumab, it's 1 injection per month. So over the course of a year, you're talking 39 injections over the course of a year versus 13. So you have 3 times the number of injections.
But any baseline characteristics where we can prefer one over the other?
There are no specific baseline characteristics. The only thing that I would say would point back to the fact that there was a greater proportion of patients who were able to come off of glucocorticoids. In terms of remission and most of the other outcomes, exacerbations, there was no significant difference. The 2 major differences were, 1, the lower eosinophil count achieved with benralizumab, and 2, 41% versus 26% of patients were able to come off of glucocorticoids with benralizumab versus mepolizumab.
So, and any differences on the background immunosuppressive drugs, those who were already on steroid or cyclophosphamide, and any difference in responses you found in the study?
I couldn't catch what you said. If you could say it a bit more slowly.
Any difference of response based on the background immunosuppressive study, which the patient was already on?
No, I showed you the forest plot, which showed that there was some slight difference in patients who were on prior immunosuppressive therapy, that it was there was a greater efficacy with mepolizumab versus benralizumab. But other than that, I don't read too much into that. Again, the numbers were small, and it's hard to explain that based on mechanism.
Sure. Thank you, sir. Mansi?
Good evening. Great study, sir. So my question is basically about the recruitment. So what I gather from the discussion and also from the study, what I read, that if we take that EGPA is kind of, we have 2 phenotypic presentations. One would be an eosinophilic dominant presentation and one would be a vasculitis predominant presentation. Then when we are comparing 2 drugs and pitting them against, each other in a head-on trial, why recruit patients who are ANCA negative and low eosinophilia? Isn't it better that the patient population, even in your trial, the patients were already sort of enriched for the eosinophilic phenotype? So if we are to compare the anti-IL-5 therapies as such, why not take just those patients who are eosinophilic driven, and then probably we would have, a more robust trial that way? Or I don't know, maybe it's just a question. So what is your thought on that?
Everybody was eosinophilic at some point. So everyone was on steroids. But
not at the time of recruitment. During recruitment, probably we were already taking some patients who were already under remission. So that is...
Yeah. So No one was in remission at the time. You had to have either relapsing or refractory disease. And the definition of remission was being on 4 milligrams or less and having a Birmingham vasculitis score of 0. So no one could get into the trial unless they were on more than 7.5 milligrams a day of prednisone. So this is a rare disease. It's hard to do clinical trials in patients with rare disease. Could we have lowered the threshold of eosinophil of prednisone down to 5 or required people to have an eosinophil count? Yeah, but the goal here was to demonstrate that there's efficacy in terms of reducing glucocorticoid dosing in patients with EGPA that's refractory or relapsing. And what we demonstrated is that both of these therapies are effective and help facilitate glucocorticoid withdrawal. They help get patients into remission. If you recall from the MIRA trial, only 3% of patients with standard of care prior to use of anti-IL-5 therapy were able to achieve remission versus 31% of patients treated with mepolizumab. We got 10 times as many people into remission, getting them down to 4 milligrams or less. In this trial, we did even better. We got around 60% of patients into remission. So, these studies were well executed across patients who had a significant unmet need in that they had significant burden of disease, a history of significant burden of disease. They also had significant steroid use that was either relapsing with frequent exacerbations or refractory. We're continuing to do more trials in this space. We're doing a study with a JAK inhibitor. We're doing a study with an ultra-long-acting anti-IL-5, depemokimab. And it's not easy to recruit for these rare disease trials. So we have to have general broad criteria and demonstrate good efficacy. Yes, it would be great to do. We've done all sorts of different sub-analyses, and we've shown that all of these different groups do quite well. We've also evaluated the long-term extension study data. I didn't show you that, but I presented that at the American Thoracic Society meeting this past year, showed that patients who switched from mepolizumab to benralizumab in the second year of the study, they ended up doing better as well in terms of eosinophil reduction and steroid reduction.
Thank you.
Dr. Milind, would you like to ask?
All right. So I think it's like kind of a conclusion, if I may ask. If I were to choose tomorrow, a patient walks into the clinic with EGPA, am I wrong in choosing benralizumab over mepolizumab, or just give the choice to the patient?
I personally would choose benralizumab over mepolizumab for the reasons I stated.
Yes.
1, there's a greater reduction in eosinophils. 2, there's a greater proportion of patients who achieve glucocorticoid withdrawal, whether it's 50% reduction or 100% reduction. 3, there's only 1 injection per month versus 3 injections. 4, there's an overall reduced cost associated with benralizumab, 30 milligrams a month versus 300 milligrams of mepolizumab a month. So I personally would choose that. You could also ask, should I choose rituximab versus an anti-IL-5? And I generally would choose an anti-IL-5 over rituximab unless there's a compelling reason with significant ANCA positivity, with significant organ damage that's associated with ANCA positivity.
Got it.
Dr.
Right.
Asmita?
Asmita ma'am had a question. Ma'am, if you could unmute yourself and ask it.
Yeah. Professor Wessler, I would like to ask that I actually treated a patient with Mapoli and Benroli who was a relapsing and actually steroid resistant with rituximab resistant everything, and even Mapoli and Benroli also did not work, and that made me think that just control of inflammation, eosinophilic inflammation in the disease, which is actually immune mediated inflammatory disorder. I believe control of inflammation of eosinophil may not give sustained remission forever? What do you think? Like maybe there will be remission for a time being, but the other inflammatory pathway might become active other than which is driven by eosinophil. That is what my thought process was.
Yeah, I agree. There are many pathways that are active in patients with EGPA. There's the eosinophil-mediated pathway. There are other type 2 inflammatory pathways that are mediated by interleukin-4 and interleukin-13 and TSLP, amongst others. And then there's the B-cell mediated pathway with ANCA positivity, and then there's neutrophilic inflammation as well. So you're right, not everyone achieves complete response. And you saw in this study, close to 60% of patients achieved remission, but 40% didn't. So for those patients, you have to think about other options. So you have to evaluate what other biomarkers are going on and what else is active. For some of those patients, what I do is I give anti-TSLP therapy with tezepelumab. And published earlier this year, so first of all, there's an ongoing study comparing tezepelumab versus placebo in patients with EGPA. They're allowed to be on anti-IL-5 therapy. But also there was a study published by Alexandra Nanzer and David Jackson in Chest in January of this year, I think it was in January, which demonstrated that tezepelumab was effective as an add-on therapy in patients with EGPA. Tezepelumab blocks TSLP, it works upstream, it blocks beyond just eosinophils, it blocks other type 2 mediated pathways, including IgE and IL-4 and IL-13 mediated pathways. So that would be a strategy that I would consider, but we need to see a bit more double-blind placebo-controlled data, and hopefully those data will emerge in the coming months.
Thank you.
So, Professor Michael, yeah, once we start the patient on benralizumab, for how long we have to continue the benralizumab to achieve the remission? And after remission, how long we have to continue the benralizumab?
It's a great question. Patients ask all the time, do I need to be on this therapy for the rest of my life? So you have different options. When someone has achieved remission, first of all, I'll continue it for at least 1 year and give it 1 year based on the data from the Mandara trial. But for patients who have achieved remission, you have 4 different options. One is you can continue their background therapy and continue their anti-IL-5 therapy. 2, you can stop their background therapy and continue their anti-IL-5 therapy. 3, you can stop the anti-IL-5 therapy and continue their background therapy. 4, you could consider increasing the dosing interval of the drug, so in an off-label manner. So obviously, continuing both the anti-IL-5 and the background therapy, patients who are in remission, they'll continue to be in remission most likely. If you stop the biologic, just stop it without increasing the dosing interval, many of those patients will relapse. We've seen that in asthma studies. There's about a 50% relapse rate within the year in patients who discontinue biologic therapy. We saw from the Shamal study that was published in The Lancet by David Jackson that for patients who continue their benralizumab and stop their background therapy, their inhalers, for instance, many of those patients do well. And so you can advocate for stopping or cutting back on background therapy. But there is a risk of loss of lung function in those patients that's reflected by elevations in nitric oxide. The 4th option, which is what I do with many of my patients, is once a patient achieves remission, I'll slowly increase the dosing interval from every 4 weeks to every 5 weeks to every 6 weeks. We're doing a study now evaluating the efficacy of that strategy. Some patients are able to achieve and sustained remission with increasing dosing interval. And if I can get people to beyond 3 months intermittent dosing, then I feel comfortable stopping the drug. We can always restart it. But what I do it very slowly over the course of 1 to 2 years. And that will free them from frequent injections? But it's a really important question that comes up.
Right. Manu.
Thank you.
I have one more question, Professor Wexler, regarding the adverse effects. You had talked about COVID being the most common side effect, 21% and 27% respectively. So, did we compare with the non-biologic population or the general population? Was COVID higher in this trial? And secondly, how was the immunosuppression IL-5 handled during the time the patient had COVID?
Yeah. So immunosuppressants were continued during the study unless otherwise clinically indicated, but we didn't want to confound things by changing those things around. The study occurred during, obviously, the COVID pandemic, and we see this with other clinical trials as well. The rates of COVID were relatively small. 21 to 27% of the population developed COVID. Again, this is during the COVID pandemic. These numbers are relatively small. We've done other analyses of patients on biologics. There is no increased risk of getting COVID while you're on an asthma biologic. And if you're on an asthma biologic, there's no worsening response to COVID vaccines when you're on a biologic. We've looked at antibody levels of the vaccines, no difference. We've published on that in the American Journal of Respiratory Critical Care Medicine.
All right, thank you, sir.
Continuing immunosuppression while the patient had COVID, was it risking worsening of COVID?
Was there? No, I don't think that we got down to such a granular level. I can tell you from other studies, people don't have worsening of their underlying asthma or EGPA in the setting of COVID, and while they're on a biologic, and they are no more susceptible to COVID on a biologic.
All right.
Small question.
Yeah. So, Professor, we have, because as you very rightly said, this is a rare disease and doing trials on this is difficult. So, India also, we are trying to kind of assimilate our data. So, Dr. Chinkita is here with us today, and she would be presenting some original work which has been done in this regard. So, if we'll let you go after, just a brief presentation from Dr. Chinkita, and we promise we'll end it in 5 minutes. We understand that you have to leave. So, Chinkita, all yours.
Yes, sir. Good evening, sir. Sir, can you see my screen?
Not yet.
Not yet. Yes. Please go ahead.
Hold on.
So this is a recent data. Good evening to everyone here. And this is a recent data I published in December 2025 from a North India severe asthma clinic. It was a 3-month follow-up of EGPA patients where our cohort was of 24 number of patients. The profile of the patients was that 83% patients were asthmatic at the time of diagnosis when we recruited them as EGPA. 42% patients were ANCA positivity, and they were female predominant with mean age of 57 years. All the patients were diagnosed as EGPA based on the standard LULA criteria 2022 guidelines. We studied them on the basis of HRCT scan, their sinus CT PNS was done, all the skin involvement and neurological involvement and cardiac involvement all were studied at the baseline and then the follow-up. 88% of the patients were biopsy proven, where biopsy was taken either from the skin or the TBLB was done. So we found that in the HRCT findings, patchy GJOs was the most prominent finding that we could find in 54% of the patients. 50% patients of our cohort had skin involvement. Then 75% patients had sinus involvement, and only 4 patients had neurological involvement as peripheral neuropathy. So we studied their acute eosinophilic count, their IgE levels as at the baseline. Then we studied their lung function test as FeNO and FEV1 at the baseline, and then we also studied their symptomatic by ACT, asthma control test. So we found that after 3 months of treatment of benralizumab, their eosinophilic count, mean eosinophilic count came down from 671 to 288. Their total IgE reduced from 1100 to 550. Their FeNO reduced from 30 to 13. Their ACT improved from 15 to 20, and their FEV1 also improved from 55 to 71. So we concluded that after 3 months of follow-up, that benralizumab, along with all the symptomatic treatment that patient was having, that benralizumab helped them achieve their disease remission with just a single injection that we could give the patient. And we're still following up these patients so that we could see how long the benralizumab can be given to the patients and what is the 1 year data that we could publish later on. That was the
Thank you. Thanks, Chinkita. So, Professor, we are trying to generate some Indian data on this as well. And before I let you go, just to close the topic, Professor, this forum is from a journal which has been newly started, and our audience today is all young pulmonologists from India who are just learning the ropes and tricks of writing papers on how to do research. So, just passing thoughts from you, if someone wants to do this kind of a study, what would be your suggestions? Can we join hands from different centers across the country and pool our data? You think we can go retrospectively and assess whatever data we have, or you think doing a prospective study would be better? So just some, answers, some food from thought from your side for research.
Yeah. So, there's a lot of ways to embark on these kinds of studies. The first thing you can do is what I generally recommend is do some kind of retrospective chart analysis to validate a hypothesis. You have to have a hypothesis and then go back and take a look and see whether or not your hypothesis is valid in a cohort that you already have on a specific therapy. Now, you may not have patients on a specific therapy. So if that's the case, that if you have a hypothesis, then it's okay to do a small pilot open label study of anywhere between 10 to 25 patients and see whether or not you can validate that. That's what we did with mepolizumab initially. That's what we did with benralizumab initially. And we did it in, just 10 patients at a time. We showed, oh, wow, it seems like it works, but we need to do a randomized double-blind placebo-controlled study. It's hard to do a randomized double-blind placebo-controlled study in a single center, especially for a rare disease. And that's why initially, when I first proposed the MIRA trial, it was going to be just 6 centers in the United States, and we were going to study 60 patients. But the other take-home message about that is that there are, we realized that would be great, and we would get good data. But the pharmaceutical company said, well, if we want to do this as a registration study for this rare disease, we'd like to get more centers and more sites and more subjects. So the initial MIRA study went up to 136 patients and went beyond our 6 to more of a global study. I could tell you that in France, what they have is they've got a vasculitis clinical research consortium. And I think it's important to do group science partnerships, especially for rare diseases. So again, retrospective analyses, small pilot studies, and then if you want to do a larger clinical trial, you can do it nationally with other centers in your region, or you can try to partner and be part of a larger clinical trial network. And that's what we've moved on to for many of these registration studies.
Thank you. Thanks. And that really helps, the younger colleagues who are here today, and all of us would want to take this up in the future. So thank you, Professor Wexler. We know you have to leave, and you were able to squeeze in this time for us. We are really thankful for having you here. Fantastic work again. And it does, lead to a lot of research questions, which I'm sure all the pulmonologists who are listening to today would carry home and would probably want to do something regarding this. Thank you so much again, Professor Wexler. You may leave now.
Arjun, just wait. I have one last question to Professor Michael, that we discovered EGPA because these severe asthma patients, once they were shifted from once a month benralizumab to once in 2 months, something started happening, because at the same time we were trying to decrease their oral corticosteroids. So I think we did two things which messed up and led to flare up, where we could actually see the skin lesions coming up, lung lesions coming up. And the first instance, we thought it is benralizumab reaction, and it came out to be actually EGPA. So is there anything like that which you have also observed in your practice?
Yeah, actually, my first EGPA patient from 1998, so 28 years ago, 1997, 29 years ago, was a patient who was put on a leukotriene modifier, zafirlukast, in the context of severe asthma, and that was dependent on corticosteroids. And her asthma got better when we started the zafirlukast at the time, but when we started to taper off the glucocorticoids, the manifestations of EGPA became manifest. Skin rash, neuropathy. Initially, we thought it was a drug reaction, but then we reviewed the literature at the time, and there's an entity called form frust of EGPA, which is basically EGPA in the context of glucocorticoid withdrawal. And in that context, the underlying glucocorticoids are suppressing the manifestations of EGPA. And when you withdraw the glucocorticoids, that's when the disease becomes manifest. So yes, and we've reported on that with zafirlukast. We reported on that with montelukast. We've reported on that with omalizumab, and we've reported on it with dupilumab. So this is a well-known phenomenon, and if you unmask the underlying disease, you're going to see these kinds of manifestations in a patient population that is at risk for having EGPA that wasn't previously considered. We don't think that the drugs are causing them, but there's likely an underlying process that's going on.
Thank you. Thank you very much.
Thank you, Professor. Thank you again for your time.
Yeah, and thank you so much. And, I've never been to India, so I'm happy to come anytime.
Sure, we will definitely love to have you in coming PACS next year. We'll send you the dates. Please block your dates.
Perfect. Thanks so much.
Thank you.
Bye-bye, everybody.
Thank you.
Thank you. Manu, all yours.
For the next article, we'll be having Dr. Mellin here with us. We'll be presenting the next article, the dipstick in pleural fluid. Do we have Dr. Mellin here?
Yes, I'm here.
Yeah. Hi, Merin. Welcome. Again, when we do this forum meeting, we do one article from an international author, and the other article is from one of our articles which has been published in PACS, and we try to take up the articles that are gaining traction, and people have been asking about those articles. So this is an article from Amrita Kochi. Asmita ma'am is here with us today. It's a very interesting way of doing indigenous research, and how new research ideas would come to younger people, and how we can do something about it. So Merin, all yours.
Thank you, sir. Good evening, everyone. I'm Dr. Merin, and I'll be presenting the study, which is role of dipstick test in expedited diagnosis of pleural effusion. Just one second. So this study was done by Dr. Asmita ma'am and Dr. Rashmi, and it was published in PACS on 31st March 2026. As pulmonologists, pleural effusion is one of the most common cases that we encounter in our OPDs and our casualty. So after we recognize the patient has pleural effusion, the next main step is to identify if it's a transudative effusion or an exudative effusion, because our treatment heavily relies on that. But the current challenge that we face is that this classification is based upon the lights criteria, which requires simultaneous testing of the serum and the pleural fluid. And there can be significant delay in this diagnosis, which also delays our clinical decision making. Also, there are only limited point of care options that are available at this point. So the rationale of our study was to see if there exists a reagent dipstick which could provide a rapid, inexpensive bedside adjunctive test to our gold standards. So this study was inspired by these two studies that were published, one of them published in ERJ as well, which tried to prove the effectivity of reagent testing in our day-to-day clinical practice. So the objective of our study was to assess the diagnostic performance of pleural fluid dipstick testing to rapidly differentiate transudate versus exudate and infectious versus non-infectious effusion compared with the gold standards. This was a prospective observational study, and the study setting was a tertiary care academic hospital. And we included all the patients with undiagnosed pleural effusion, and only patients who refused to consent were excluded from the study, including patients with history of bleeding diathesis or trauma-related effusion. So the framework was all the patients with undiagnosed pleural effusion. The index test was a protein dipstick and a leukocyte esterase test. The comparator to classify exudative versus transudative was our lights criteria, and infectious versus non-infectious was classified on the basis of microbiological testing and clinical or radiological evidence of pneumonia. The primary outcome was sensitivity and specificity, whereas the secondary outcome was positive and negative predictive value. So this dipstick, protein dipstick, had a scale of 0 to 5, and anything more than 3 was considered to be positive for exudative effusion, whereas the leukocyte esterase dipstick had a grade of 0 to 4, and the threshold was 2. We did a statistical analysis using the MET calculator. We calculated the sensitivity, specificity, PPV, NPV using standard 2x2 contingency table. So the total number of patients that were enrolled in the study was 73, of which 64% were male, 36% were female, and the most common type of effusion was exudative, which accounted for 91.78%. Another, the etiologic distribution was, we saw in our study, the most common cause of effusion was tuberculosis, closely followed by malignancy, 30.1%, followed by infectious non-TB effusion and transudative effusion. Coming to the result of the protein dipstick, we saw that in non-infectious transudative effusion, 66% of the time it was grade 1, that is, it was classified correctly. 33.3% of the time it was misclassified as exudative effusion. And in non-infectious exudative, it was classified correctly 80.8% of the time. Infectious effusion was also classified correctly 75% of the time. The results of the LER dipstick was, interestingly, we saw that non-infective transudative effusion, non-infective exudative effusion, and tuberculous effusion all were grade 0. So 100% of the time they were classified into the correct group by this LER dipstick. And infectious causes of effusion were classified correctly 75% of the time. So the key insight that we get from the protein dipstick result is that when the protein grade is more than 3+, there is a strong positive predictive value of 96.6%, and therefore it can be used as a good ruling in test. Whereas the leukocyte esterase test showed specificity for bacterial infection, and it was negative for all tuberculous infections. So this LER can be used as a rapid bedside test to exclude bacterial infection and guide antibiotic therapy. We compared our study with the previous studies that I mentioned, and we saw that it showed good concurrence. Even the study done by Porcel et al. And Kalesian, the tuberculous and non-infectious causes of effusion were 100% of the time grade 0. Limitations of the study, it was a single center study. We couldn't include blood-stained effusion, so it limits the applicability, and it cannot distinguish neutrophil-rich effusion. So the key take-home message is that if, when you use this reagent stick, if protein is more than 3+, it is likely exudative. If LER is positive, with high confidence, we can say that it's an infective exudate. So this test can be used as an adjunct. It's not a replacement for a standard diagnostic test. So it's a good point of care test, especially in resource-limited settings. Thank you.
Thanks, Miran. That's a short and a sweet presentation, and that's what exactly we wanted. So, Miran will ask everyone to pitch in, and I'll start with a very simple question. So, dipsticks, we've been using for a long period of time, and in the emergencies, especially in general medicine emergencies, it's something that you do in and out for decade. One of the biggest problems with dipstick testing is that inter-observable variability is very high, especially with glucose and things like ketones. There used to be always be these arguments: what would be positive for someone would be negative for the other. So how do you minimize inter-observable variability in this?
So it's a calorimetric test. So we have the color reading in the bottle itself. So
yeah, of course it's there, but the way everyone it's always a kind of a confusion. 2+, 3+. What one would say 4+ would be others 2+.
So this is just an adjunctive test. We cannot replace our main gold standards, but this could give us an idea bedside if it's an infective effusion, if we have to start antibiotics upfront, or if it is a transudative or a tubercular effusion. Just an idea till we get the final results from the lab.
All right, so now your paper has been published, and so are you actually doing this in your clinical practice? Have you incorporated this, or you would need more multicentric data from this?
We are yet to incorporate, and more data would be good.
So I think that is the only that is the basic pretense, that is the basic purpose of starting these series. That these are indigenous research ideas. There are young minds who are listening to us today, and no research, no study question is a small study question or is a silly question. As we keep saying that we need more data from India, and for Indian problems, we keep asking the Western world to give us data. What we need is our Indian data. And I think these are simple research ideas which don't require a lot of input, which are not expensive. And these are the things, where we need to do combined, studies and do kind of hand holding so that we can help each other, right? So Manu, if you can take this forward.
Thank you, Dr. Merin. It was a wonderful presentation. Congratulations on the work, Dr. Merin, Dr. Merin. Just for the sake of our students, so how does a urine dipstick detect protein and leukocyte esterase?
So the protein dipstick, it has an indicator dye. It's a special kind of a dye. So normally indicator dyes will change color only if the pH changes. But in this case, this dye, it's tetrabromoxol. It follows a principle called protein error. So when the protein combines with this indicator dye, there will be release of hydrogen ion and the color will change. And depending upon the concentration of the protein, the color will intensify or deepen, depending upon the concentration of the protein. And for the leukocyte esterase reagent as well, it's the same thing. The leukocyte esterase enzyme will combine with the substrate, which will lead to formation of azo-purple dye, which will give the purple color. And the color intensifies based on the concentration.
Okay. So as you said, this is a pH-dependent reaction.
Yes.
And these sticks are basically used for urine, which has a different pH. And we are using it in fluid, which is a different pH of more than 7. Does it hamper the results? Or have you encountered something which is giving false positive?
Threshold, what we have taken is according to the studies that were done previously. So these are validated thresholds for pleural fluid, not for urine. So that's why the results would be accurate, more accurate.
Okay. Dr. Mansi, if you would like to add on something.
Just, obviously every research is good, like Arjun has already said that, but I just was intrigued with what crossed your mind while doing this research. When we are actually evaluating pleural effusions, are you facing any problem in the current criteria? Like, why use a dipstick test which is not going to give you anything very substantial in terms of patient management. I mean, leukocyte esterase test, yes, it has kind of got good, it is backed up by the data previously on other samples. But would it really change our practice? And how do you really, position this test in your practice? Adjunct is a very loose term. But if I have to, from your paper, I'm getting that leukocyte esterase was basically a good diagnostic accuracy. It showed some accuracy. But would it change my practice in any way? Are you suggesting that based on that thing, we take some urgent decisions? Can you just highlight something on that?
Ma'am, in a tertiary care hospital, I don't think it would be of much use, but in a resource limited setting, definitely. And especially if we get a patient of pleural effusion on a night duties, and if you could do this bedside test, based on the LER test, at least maybe we can start upfront antibiotics, and then it could differentiate between tuberculous, non-tuberculous in a resource limited setting. Tertiary care hospital, the applicability would be limited.
Dr. Shweta?
Dr. Marin, is it scientifically valid to use the urine dipstick test for the pleural fluid analysis?
Sorry, ma'am, I couldn't.
Is it scientifically valid to use the urine dipstick test for pleural fluid analysis?
Yes.
Because the protein content may be different, the characteristics of the protein present may be different.
Ma'am, it is a urine dipstick, but the threshold has been validated by studies done on pleural fluid. So it is not giving us the values that that would come for urine when we use it as urine dipstick.
And do you think that like extension of your studies, like pleural specific urine dipstick tests would be more scientific? We could work on that lines, more innovation and something like that.
Yeah, ma'am.
Dr. Elias?
Quantity of anaerobic culture of premature is when you grow in the anaerobic organisms of the infectious.
Dr. Elias, you were not audible.
Am I audible now?
Yeah, please go ahead.
I was asking whether anaerobic culture of the pleural fluid was done, and did you grow any anaerobic organisms?
So we did culture, and of our 16 infective exudative effusions, only 3 of them had organisms growing, 2 of which was E. coli.
No, I'm saying anaerobic cultures.
Anaerobic, no, not specifically.
The problem with that is that, see, if you miss anaerobics, you are missing 25 to 30% of cases. So you will mislabel them as non-infectious exudative patients. So that is a huge flaw because they will not grow normal culture.
So, but it depends on the hospital where you practice, because in our hospital, I am yet to come across any anaerobic effusion. So maybe in Srinagar it might be very common, but in Amrita it is not.
All right.
But it has to be separately grown, ma'am.
Yeah, but in our hospital policy, every hospital will have some policy. So we send 2 sets of aerobic cultures.
All right. Point well taken. I think Talwar sir has raised his hand.
I think a very good discussion on aerobic. We generally, the aerobic cultures are very difficult to send. So I think unless and until you suspect, it will require a specific collection methods and specific collection to be quickly transported to the laboratory for processing also. This is a little difficult. But Marin, I was just wondering, if the infection is the major thing to look into this, can you think that tomorrow in ascites it will have role where bacterial peritonitis is a very big issue and you want a quick result so that you can take a call, because it is something which is all the time in the mind that is this ascites infected or not, especially in patients with CLD.
It's being done for detecting spontaneous bacterial peritonitis, sir. There are studies on it.
Okay, I think that makes very interesting, that because that's where you need bedside answers. Tomorrow you tell me CSF can be tested like that, I will say yes, that's the bedside where you really need, because emergency is at that point of time. But I have one more thing. Many a times we find in the periphery the samples of the pleural fluid are drawn but no test done at all. So if they have this simple stick available, at least they can perform this much of test and say that more tests are required, and they are not able to do that. Because I've seen even the peripheral centers just tap the fluid but don't do the tests. And that's something where you can actually, they have dipsticks, they can do it. So maybe it can be extended to the primary care, or maybe secondary care, or some small towns where we have seen the people in the ultrasound even tapping the fluid but not sending the tests.
Sure. It's a point very well.
Arjun sir, one question to Merin. Like when we use this urine dipstick test, would it also show a corresponding pH by any chance?
No, sir, not in this
It does.
region.
Because few of the dipsticks can have a pH range as well. Like, so if you have that, then anything that is less than 7.2 can help us in guiding whether you have to drain the fluid or put an ICD as per the lights criteria of a complex, complicated effusion. That is one point. And second thing is, as Talwar sir said, finding out the infection. Actually, if the leukocyte esterase comes highly positive, then possibly it can be a parapneumonic rather than a tubercular effusion, which is generally will not have that high levels of leukocyte esterase. So sometimes we see even if the ADA is high, despite having neutrophil, people tend to start ATT. So maybe if you find the leukocyte esterase coming positive, then possibly it's a parapneumonic, whereas the leukocyte comes negative, then possibly you think more in terms of TB if your ADA is also fitting into the 40 to 70 group. So maybe these are the extensions of the study that can be done. But if pH monitoring is also there, then because we generally don't send the pleural fluid into the ABG machine, fearing that the ABG machine gets clogged by the pleural fluid. But if there are some modified dipsticks which can measure the pH range, then that will help in management aspect as well.
Sure. So, Vishwesh, this whole project, the whole point of taking up this research is because, and presenting this paper is because it is simple, it is doable. The lights criteria was the MD thesis of one of the students in Cleveland Clinic. So there are young, impressionable minds here, and our purpose of doing this meeting, PACS Forum, is to give these kids ideas that these are simple, doable projects, and we need to exchange ideas. So we all understand this is a very nascent project. This is something which has been taken up probably as an MD thesis topic, but that should not hold back anyone from publishing. And that is a very important message that we want to give you today, that it is difficult for Indian students, young people, pulmonologists, young researchers to publish. The journals that we have are, unfortunately, the amount of work that can be generated from India, it's overwhelming. And the problem is most of the international journals are paid, they are very expensive. And when you send good data to Indian journals, when we collect that data and when we publish it, it helps Indian journals get indexed very fast. And once indexing is done for Indian journals, you can use it for NMC purposes, for your teaching promotions. And within 2 years, if a journal is indexed in good, basic indexing agencies, there are now expedited processes wherein you can actually take the journal to PubMed indexing within 2 to 4 years of starting a journey. So a humble request, Merin, fantastic work. Young people need to do this kind of simple work which can be published in Indian journals, and that is the only way we will take Indian research ahead. You cannot expect someone sitting in the Western world to do this kind of simple basic research. Only we can do this, right? And then fantastic idea. It's a very basic idea, but I really like this paper. There can be very, yeah.
Arjun, hi. Yeah. So, yeah. Sorry. Okay, just a second. So, Merin, now what I gather from the study is that this leukocyte esterase was a stand out from the study. I mean, not the protein one, but the other one. And this study, you should take it as an extension. Like Arjun has said, that it should be primer for the further research. And where it stands for me, I would be really happy to help. It helps in distinguishing all your tuberculous pleural effusions. They showed negative result for leukocyte esterase, and that is where the confusion comes in India, where you have an effusion which is moderate size, unilateral, and you have to even neutrophilia and ADA, some of all these things can still be hodgepodge. So there you should plan a study wherein you have an exudative effusion, so you can have a now a very focused study from your preliminary work that you have to test on leukocyte esterase, particularly in distinguishing TB from non-tuberculous infected diffusions. There it will become a very, interesting, and, I think it should yield good results.
See, that's the whole
Sorry.
point of doing this meeting. Mansi has come up with such an excellent point, and that's a very, very good research idea. So hopefully, Mansi, next year you will be presenting that at PACS. You can give it to one of your, you give it
Yeah,
to
sure, sure.
one of your PGs, and I promise we'll publish it in JPACS.
Sending you more work. It just slipped out of my mind. I'm sending a lot of things now to you.
Thank you so much. We'll be very, very happy to take them up. Right. So any of the panelists have any other questions, or can we move to the most interesting part of it? I've been getting all these questions from young PGs who are waiting for Deepak's quiz. So if there are no more questions, I'll thank Merin and Asmita ma'am for being with us today. Right. And over to Dr. Deepak Prajapati with his questions.
Hi, very good evening, everyone. And as all of you know, that there is a quiz session in the last, and those 3 members who will give the right answers and quickly, they will get the chance to win the Amazon vouchers. So I request backend team to start the poll. So our first question is, in the Mandara trial, benralizumab was compared against which drug? Omalizumab, option A, option B, dupilumab, option C, cyclophosphamide, and option D, mepolizumab. Move on to the second question. The sustained remission as per Mandara trial required. Option A, BVAS 0 at any single time point. Option B, BVAS 0 plus no steroids. Option C, BVAS score of 0 with prednisolone dose of equal or less than 4 mg per day at both weeks 38 and 48. Option D, BVAS score less than or equal to 1 with prednisolone dose of less than or equal to 10 milligram per day. So all these things has been discussed by Professor Michael. So all those who attended this session, they will be able to answer. So the third question is, which is the most appropriate interpretation? Option A, benralizumab should be first line over all therapies. Option B, both biologics are interchangeable in all EGPA phenotypes. Option C, benralizumab offers a practical alternative with less frequent dosing. Option D, mepolizumab is obsolete. So please participate in the quiz, and you have chance to get the Amazon vouchers. So the next question is, the steroid related outcome showed option A, no steroid taper allowed. Option B, significant superiority of benralizumab. Option C, comparable steroid reduction in both the groups. And option D, only mepolizumab reduced the steroids. The fifth question is, what are the approximate remission rates in Mandara trial? Option A, 10 to 15% in both the arms. Option B, 25 to 30% in both the arms. Option C, 50 to 60% in benralizumab and 20% in mepolizumab arm. Option D, more than 70% in both the arms. Last question is, which subgroup was included in the Mandara trial? Option A, newly diagnosed EGPA only. Option B, only ANCA positive EGPA. Option C, relapsing or refractory eosinophilic granulomatous with polyangiitis. And option D, only severe renal vasculitis. So this is all about the poll questions, and the winners will be announced in the next episode. And sir, over to you.
All right. Thank you, Deepak. And I thank all the panelists for taking out time today. All of you guys are doing so well with your, with your clinical work. And I would really appreciate, if you could, like you have been doing, kind of when we opened this, our main aim was to promote more Indian papers, generate more data from India. Now we have an instrument where we can actually go ahead and publish it. So Ilyas, Mansi, Milind, Vishwesh, all of you work with young, impressionable minds and have fellows and residents. And please let us join forces and do get some data out of India. Very unique Indian problems we have, these pleural infections, post-TB sequelae, and yet no data exists because probably we've not been doing it in the past. But I think, as Sir had said, that publish or perish. So I think it's now time to publish, and we all need to really do that. So with that, I thank all of you for being here today. Me, Talwar sir, Deepak, and Manu. We four of us are very thankful that you could join us today and spare your time and be with us. Thanks again, guys.
So I have one announcement that those who missed today's session, they can go and see it on the PACS website, the pacsfoundation.com, and the results will also be seen or uploaded on the website. Thank you.
Thank you, everyone. Thank you.